Good afternoon, everyone, and welcome to today's Lunch and Learn webinar session entitled Social Determinants of Dental Health. I am Shannon Robertson, Interim Clinical Quality Director with the Louisiana Primary Care Association. Our presenter for today is Drew Bunker, fourth year Tulane University medical student. During this one-hour presentation, he will discuss the social determinants of dental health and the disparities that exist nationally and in Louisiana. The presentation will include oral public health concerns, integration of dental health into primary care practice, and the programs as well as efforts aimed at improving oral health in underserved populations in Louisiana. Just a housekeeping item, during the webinar, all participants will be in listen-only mode. Please type in your question throughout the broadcast in the chat box or click the option to raise your hand located on the webinar screen and I will unmute your line. All lines will be unmuted after the presentation for questions. If we run out of time, you can email your question and we will follow up with you after the webinar. Our contact information will be displayed at the end. Thank you for participating in this series. Drew, you may begin.
Hello, everyone. Hope you can hear me well right now. So, as Shannon described, this presentation is going to be on the social determinants of dental health. This presentation was started by two other Tulane medical students, David and Harrison, and I continued their work. So what is dental public health? Dental public health is the part of dentistry providing leadership and expertise in population-based dentistry, oral health surveillance, policy development, community-based disease prevention and health promotion, and the maintenance of the dental safety net. The major topics of this discussion today will be oral public health concerns, Louisiana and national dental health statistics, integration into primary care practice, social determinants of dental health, dental service shortage, and community dental health coordinators. So just going into this oral public health concerns, epidemiological studies have shown a link between periodontal disease and cardiovascular disease. Dental plaque control also decreases the prevalence of H. pylori in the stomach. An increase in periodontitis occurs after menopause. Periodontal disease is associated with preterm delivery and low birth weight, and treatment of periodontal disease pre-pregnancy has led to lower levels of preterm delivery and low birth weight. Periodontitis worsens glycemic control by the release of inflammatory mediators, and actually treatment of periodontitis leads to 10 to 20% improvement in glycemic control. Xerostomia, which is dry mouth, is caused by certain medications and increases risk of dental caries and periodontitis. And nifedipine in the treatment of type 2 diabetes increases the risk of periodontal disease. And further into the oral public health concerns, oral HPV infection has been the cause of an increased oropharyngeal squamous cell carcinoma incidence, and tobacco use and heavy alcohol consumption are the two principal risk factors and are responsible for 75% of oral carcinomas. So why does periodontitis, dental caries, why do those all matter? Well, oral pain leads to poor school performance, loss of work in adults, difficulty chewing, and inadequate nutrition. And dental decay aesthetically can be detrimental and is also very costly for restoration. So more on dental caries. Dental caries in the pediatric population it's the most common chronic disease of childhood. It's ahead of asthma. 30 to 50% of low-income children have dental caries, and actually 80% of caries occur in 20% of the population. Hispanic and non-Hispanic black children are 2 times more likely compared to non-Hispanic white children to have dental caries. And the oral health risk assessment tool, which I provided the link, is something that was developed by the American Academy of Pediatrics and the National Interprofessional Initiative on Oral Health. And this is a tool that helps physicians and health providers identify patients who are at risk for dental caries. And part of what this risk assessment tool is, it puts patients into risk groups, and high risk and moderate risk. And I won't go into the specifics, but high risk, the big factors are the plaque on the teeth, the presence of white spots or cavities, and no systemic fluoride exposure. and the multiple moderate risk factors. And the moderate risk factors are the low social and economic status and poor access to health care, to name a few. So what does early childhood caries look like? I apologize if the pictures are a little blurry, but the white spot is the early stage on the tooth, as you can see in the top left picture. This progresses to the bottom left picture into brown cavitation, and then which further leads to aggressive caries, as you can see in the pictures on the right. So some Louisiana dental health statistics. 16% of Louisianans feel they have poor oral health. 21% report current appearance of mouth and teeth affects their ability to interview for a job. 93% of Louisianans value keeping their mouth healthy. 91% of Louisianans believe that regular visits to the dentist will keep their mouths clean. And 88% of Louisianans agree that they need to see the dentist twice a year. All these statistics are from the American Dental Association's website and the surveys that they have done. And as you can see from these, it's clear that Louisianans understand the importance of having oral health and seeing a dentist. But there is a large percentage that, or 16%, that believe they don't have oral health. So there's definitely a disparity there. So some of the reasons why patients haven't visited a dentist in the last 12 months, cost being number one, and fear of the dentist, as well as inconvenient location or time. Some national health statistics that are of interest is that there has been a decrease in yearly dental care in adults aged 19 to 64 from 2003 to 2011. However, children and elderly have been constant during this time period. And this national survey found that adults' top reasons for foregoing dental care was cost and belief that they don't need dental care. Also found in the survey was those below the 400% of the federal poverty line or lower income patients cited cost as the primary reason for foregoing care. Here's a graph showing the different income levels and the percentage that saw the dentist in the last 12 months. As you can see, as the income increased, the percentage that saw the dentist increased as well. So the interprofessional disconnect. More than 90% of physicians believe oral health should be addressed in well visits. However, 50% had little or no oral health training. Clinicians on average spend less than 2 hours oral health training, and they found that 91% could not answer simple oral health questions. And I can attest for this as a medical student. There is definitely oral health training in medical school. So what are we doing about this lack of oral health knowledge in the primary care setting by primary care physicians? The HRSA developed this integration of oral health and primary care practice initiative. And what they did was they found that there were certain core competencies, oral health core competencies, that all healthcare professionals should have. And this includes risk assessment, or being able to do an oral health evaluation, understanding preventative intervention and being able to do preventative intervention, communication, education on dental health, and interprofessional collaborative practice. The training that primary care physicians and health professionals can get on these competencies and on oral health in general can be done through Smiles for Life, oralhealth.org. Actually, they can receive CME credit through the AAFP and can also be awarded for receiving credit for doing this course. And this course is on that website. There's also some more information. I included a link to how practices can implement interprofessional oral health core clinical competencies into their health centers, and how programs have been successful in this. So another thing that primary care doctors can do and that other health professionals can do is fluoride varnish. And the U.S. Preventive Task Force actually recommends PCPs to apply fluoride varnish to all teeth of all infants and children, starting with the appearance of first primary teeth through age 5, at least every 6 months. However, you must be a qualified provider to apply this. Physicians must be trained, but they can actually provide training to staff. You must be a physician, nurse practitioner, physician assistant, registered nurse, licensed practical nurse, dentist, dental hygienist, registered dental assistant, or certified medical assistant. You must have a Smiles for Life certificate to be able to apply the fluoride varnish. And the fluoride varnish is reimbursable, but only when it's performed on the same date as the office visit. So just more on the fluoride varnish. The Smiles Across America program offers free fluoride varnish to health centers. Excuse me. And this can be, and more information on this is provided by the link provided. Dental sealant is another aspect of preventative care, and not so much what primary care doctors can do, but it is applied to prevent caries from developing. And actually, Louisiana is one of 30 states that requires a dental exam before a dental hygienist can see a student in a school sealant program and apply the sealant. So dentists are required before sealant can be administered. So just on sealant and fluoride varnish, sealant, Cochrane review found that sealant is very effective in preventing and controlling caries in permanent teeth, especially in high-risk children. It reduces caries for up to 48 months when compared with no sealant. The Cochrane review also looked at fluoride varnish and found that it has a caries inhibiting effect in both permanent and primary teeth. There's also a review that compared fluoride varnish versus sealant and found that the evidence to be limited and that they were not able to draw clear conclusions. However, they did find low-quality evidence that the resin-based sealant was superior to fluoride varnish on occlusive surfaces of permanent molar teeth for preventing dental caries. So basically they found that sealant, if you want to prevent caries, sealant placed on the permanent molars is better than fluoride varnish, and that's why sealants are applied to molars. And another study found that prevention of dental caries is actually less expensive than the cost of treatment for dental caries. So that's why there's so much push for sealant and fluoride varnish. There's a current UDS measure that FQHCs are this year challenged with having children aged 6 to 9 years at elevated risk receive a sealant on a first primary molar tooth. I'm sure you are aware of this. So more on the social determinants of dental health. This was an interesting statement by the World Health Organization. Say, unfair economic arrangements, poor policies and programs, and bad governance were responsible for most of the inequalities that are seen in the world. What the WHO also reported was that the socioeconomic gradient of health exists in dental health as well. And the same social determinants of health, such as access to healthcare, schools, educations, conditions of work and leisure, communities, and cities, exist in dental health. So what are some of the barriers that Medicaid and low-income patients have to seeing a dentist? What was found was the top reasons were difficulty finding a dentist who accepts Medicaid, difficulty traveling to the dentist, and perceived lack of need. And these were in addition to the barrier of cost. It has also been found that low income and those without health insurance are least likely to say they intend to visit a dentist. So dental care through the Medicaid expansion. Fortunately, the Affordable Care Act increased dental care to patients who didn't have care in the past. Currently, children may be seen every 6 months, starting with their first visit before 12 months of age until 21 years of age, and this is covered through Medicaid. This includes preventative and diagnostic benefits as well as therapeutic benefits. In addition, adults can receive dental care through Medicaid, and all 5 plans cover the dental care for adults, and these include dental exams, cleanings twice a year, fillings, extractions, x-rays once a year, for a total of $500 a year. And although they all vary in some of the things I've mentioned, it's basically what I've provided there is the basics of what they provide. So how do we improve access for underserved populations? The Institute of Medicine released a report where they addressed improving access to oral health care for vulnerable and underserved populations. And they came up with some key points. First point was creating optimal laws and regulations. Second being improving dental education and training. Reducing financial and administration barriers being third. Promoting research and expanding capacity. So one of the questions that came up when I was researching was, is there a dental service shortage? The ADA, the American Dental Association, says that the dental shortage is not the problem. They believe we have enough dentists. It's where the dentists are in relation to the underserved. And one of the things that has come up is the use of dental therapists and dental mid-levels, which are advanced hygienists, as a means to treat these patients who are not being served. And the American Dental Association reports that there's no economic feasibility of dental mid-levels. So here's a map of the health profession shortage areas for dental health. The purple is the areas of healthcare shortage, and the not areas, or that areas that are adequately provided with dentists, and the green areas are the low-income populations. So as you can see in Louisiana, we have a lot of areas that there is a shortage of dental care, and as well as a lot of low-income patients. Here is a map. This was released in 2011 by the Louisiana State Health Department, and this looked at the number of dentists by Louisiana parish. As you can see, there's 3 parishes that do not have a dentist in their parish, and there's other areas with 1 to 5 dentists. So more on federal qualified health centers and what they do for dental health. They act as safety net providers, and they organize and deliver a significant level of health care and other health-related services to uninsured, Medicaid, and other vulnerable populations. And the ways in which FQHCs can act as these safety net dental health providers is through information on how to do it. And information on how to do it is given by the link. It's the dental clinic manual, and learning how to provide this care is important for FQHCs to be aware of. So FQHCs are required to provide dental services on site or through contractual agreement. However, dental services at FQHCs remains limited. So what are we doing in Louisiana to improve care for underserved areas? So the Louisiana Oral Health Workforce Expansion Project is a way in which we're addressing these health professional shortage areas. And what this program is a program that provides a scholarship to Louisiana State University of Dentistry students who are then obliged to serve in these these shortage areas. And for every year they receive their scholarship, that year they have to give to service to these areas. And the hope is to get students aware of these areas that need dental service, and to hopefully have them stay in these areas. But if not anything, at least it ensures that a dental health provider will be there for a short amount of time. And this project is currently being established. So the Oral Health Service Expansion Supplemental Awards, I'm sure many of you are aware of this. It was a grant of up to $350,000 a year by HRSA. And I actually want to ask if anyone in this group has used this award or received this award, and could tell me about what the things that they've done with it.
Okay, Drew, at this time I've unmuted the lines. If anyone, if any health center is on the line that has received the Oral Health Service Expansion Supplemental Award and would like to speak more on it, or what your health center may be doing towards creating more access to individuals, please feel free to go ahead and give us some feedback. You can keep going, Drew. I don't
Keep
think
going. Okay. So there was a few health centers in Louisiana that did receive it, but upon receiving the grant this past year, they were tasked with adding at least one on-site full-time equivalent licensed dental provider within 120 days of award. And this was to ensure that oral health and services were expanded and that they could increase the number of oral health patients and visits and increase the percentage of health center patients who received oral health services at their health center. So other information about expanding dental health services, this can be found at the National Network for Oral Health Access. If you haven't already been to this website, they have some great information about expanding access and improving care for the populations that health centers serve. So another program that gets to the patients that are not, that maybe not seen, or that don't have Medicaid, or who are unable to see a dental provider. And this is the LA Mission of Mercy, and actually just recently happened this past weekend. It's 2 days of free dental care, no appointment necessary, and it's done by volunteers, hygienists, students all over Louisiana, and they do exams, x-rays, cleanings, fillings, all dental procedures. Not only do they do these procedures, but they also raise public awareness in these populations of people. And it's a really good program, or 2 days that happens every year. Did anyone participate in this? I'd like to open up. Did anyone participate in the LA Mission of Mercy?
Okay, lines are open for responses. Okay, you can keep going, Drew.
Keep going. Okay. Another issue that's come up in Louisiana is water fluoridation. In Louisiana, only 26.7% of the population has adequately fluoridated drinking water, and this is compared to 72% nationally. The CDC actually released a report in August of 2016, and they combined a lot of evidence and showed that that water fluoridation decreases caries by 15%, and that the prevalence of caries is reduced in all socioeconomic groups. Additionally, they found there's no evidence of community water fluoridation that results in medical or dental adverse effects. Also, they found that in an economic review that the benefits range from $1.10 to $135 of benefits for every water invested into water fluoridation. The CDC, when they came out with their report for the Health for the Future, they mentioned as water fluoridation as a big public health goal that they want to continue to push forward. And you can get a parish-by-parish report if your water is fluoridated on the website provided. And just some quick stats. So Baton Rouge has no fluoridated water, or inadequately fluoridated water. However, New Orleans water is fluoridated. So this is more information about fluoride supplementation. So the United States Preventative Service Task Force and the American Academy of Pediatrics recommends primary care clinicians to prescribe oral fluoride starting at age 6 months for all children whose water supply is deficient in fluoride. And this is not even based on a risk assessment. This is just if they have inadequate water fluoridation. However, a little bit to contrast that is that the American Academy of Pediatric Dentistry and American Dental Association really only suggests that, or doesn't suggest it, but really pushes that it should be given to high risk or high carry risk patients, even who just don't have optimally fluoridated water. So on the table at the right, you can see the different water fluoride concentrations that are in patient's water source and how much supplemental fluoride they should be receiving. Okay, so the last point I'd like to make is about the community dental health coordinators and their role in improving access to underserved populations in areas that dental care is not as good as it should be. So community dental health coordinators, they focus on reducing the oral health disparities by targeting social determinants of oral health and improving access to oral health. So what they do specifically is they arrange transportation, encourage patients to complete treatment, enhance cultural competency, educate about prevention, and they navigate the Medicaid and other dental systems of care. There are certain core competencies that these health coordinators must have. I won't go into all of them, but they should be really involved with the community and increasing dental care for the community. Not only are they act as healthcare workers, but not only are they coordinators, but they also are trained to provide basic dentistry, and that is part of their training. They can do certain procedures in addition to being knowledgeable about the dental care system for patients. Community health centers that have implemented the CDHCs have shown an increase in dental services, and information that I didn't provide, but there are actually online programs to someone for dental hygienists to be trained to be a community dental health coordinator. But they seem to be a way in which we can reach populations who didn't have care or who had trouble accessing dental care. So just conclusions from this talk. So I hope you got from what I've said today that the dental health disparities do exist in the amount of times people visit a dentist and the amount of caries that children of low income have, and that dental care access is lower in Medicaid and low income populations, and this is something that needs to be addressed. And one of the ways, a couple of the ways in which we're doing this is by increasing primary care physicians' knowledge about oral health, and we're also trying to help FQHCs or give them the opportunities to improve dental health for their patients. And this includes the oral health integration, these oral health service expansion, the awards, oral health service expansion awards, and there's also activism that can be done on the part of primary care physicians and FQHCs to improve water fluoridation for their patients. Also, the last point is the community dental health coordinators. They may be key to improving dental care across socioeconomic minority groups. I know there's not much evidence to support what they're doing, but it sounds like their mission and what they can do is very beneficial and will improve care. And it seems like an investment that is worth looking into and worth developing. So here are my references, and the contact information. I give Shannon's contact information and my contact information if you have any questions. And that is the presentation. Is there any questions?
Okay, thank you, Drew. At this time, all lines are unmuted for questions. If you have a question, please feel free to ask at this time.
Can you hear me?
Yes, we can hear you.
Okay. My question is, if I want to get more information about fluoride varnish training, where can I go? And in that same line, who do I need to be, what age or which kids need to be getting this?
Drew, are you on the line still? Drew? Okay, it seems we may have some technical difficulties where Drew may need to call back in. But as far as the information, there's a website. It's called Smiles Life Oral Health website, and we will provide that information when we send out the slide presentation. And the children that are available are able to get fluoride varnish. They're 6 months to 5 years old with the appearance of the first primary tooth. And it's normally every 12 months or every 6 months.
Okay. Thank you.
Okay, are there any additional questions on the line at this time? It appears our Tulane student is having some issues with the line, but any questions, please feel free to email myself at srobertson@lpca.net or Drew Bunker at dbunker@tulane.edu. Okay, and I want to take a moment to, again, thank our Tulane University of Medicine student, Drew Bunker, for conducting our presentation today. We will send out a copy of the slides to all attendees and post the recordings of this learning session to the LPCA website in addition to our other social determinants webinar series. And so thank you everyone for joining our webinar today and for participating. Have a great day.